Good morning, good afternoon, good evening, depending on where you're calling from. My name is Marietta Valet, and I'm the COVID-19 evaluation team leader with Tango International. And I'd like to welcome you to today's webinar, where we will share key findings, lessons learned, high-level conclusions, and some priority recommendations for future programming that are all based on the evidence from the BHA FY20 supplemental funding evaluation that was in response to COVID-19. Over to Katie to first discuss some of the key tools and interpretation technologies available today.
Thanks so much, Marietta. So before we start, we would like to inform you that this session will be recorded and that we are providing simultaneous interpretation in French, Spanish, and Arabic. I'd like to invite everyone to select their preferred language for this session. You can do that by clicking the interpretation icon at the bottom of your Zoom screen and selecting your preferred language. You can choose to mute the original audio or listen to it at a lower volume. Through our engagement activities today, we encourage you to participate in your language of choice, as we have team members here to support that translation. Finally, while our slides are presented in English, the brief that we'll be discussing today that will cover this content is also available in French, Spanish, and Arabic. We will email links to that brief in all of those languages, as well as the recording of this webinar early next week. At any time during the event, if you have questions or comments, please use the chat box feature, as we have team members who are tracking the chat and will be able to provide responses. I will now pass it over to Lenora Zena, Senior M&E Advisor at USAID's Bureau for Humanitarian Assistance and the Activity Manager of this evaluation, for a brief introduction. Over to you, Lenora.
Hi, Katie, and thank you for that introduction. And hello to everyone, and thank you for joining today's presentation on our findings. So just for a little bit of background, BHA issued the COVID-19 Evaluation Associate Award, or COVID-19 Evaluation, to gather timely evidence on BHA's response to COVID-19 in humanitarian context. This performance evaluation was started in October of 2021, and so it's been quite a long time that we've been working on this. That the Tango team has been working on this, and we've been using the ideal mechanism through Save the Children in order to do this. The key objectives of this evaluation are to evaluate the performance of activities funded through BHA's FY 2020 IDA COVID-19 supplemental assistance, and also to document successes, lessons learned, shortcomings, and unintended consequences based on BHA's response to the COVID-19 supplemental assistance. We have a huge thank you to Tango International in collaboration with Save the Children and all of the work that they have done tirelessly throughout the year to conduct this evaluation. So I think just want to say a big thank you to Tango, and we will hand it back over to you for go through the rest of the presentation. Thank you.
Great, thanks so much, Lenora. And with that, we will get going. Again, this is Marietta with Tango, and I'm going to turn my camera off, and from here, just let you focus on the slides. Okay, what did we evaluate? As Lenora noted, there were the main evaluation objectives around learning and performance. But as shown on the right on the screen here, which outlines our 11 evaluation questions, those were spread across 4 evaluation domain or criteria, and those were effectiveness of IP performance, relevance of assistance to participants, efficiency and timeliness of assistance, and coordination capacity of implementing partners, or IPs, which is under the coherence domain. The FY20 supplemental was distributed with 178 awards that spanned the BHA regions across 40 countries, plus West Bank, Gaza, and Pacific Islands, of course, also global macro awards. And that was distributed through 28 legacy FFP awards and 150 legacy OFDA awards. That was including 12 sectors total and 62 partners. Next slide. How did we answer the evaluation questions? On the screen here, there are the 5 main method areas that we used. For more information on our methodology, please refer to the findings brief that will be provided. In the interest of time, we will transition quickly to what we've learned, but here you'll see that we conducted country case studies, which was an in-depth examination of awards in Nigeria, Iraq, and Colombia. It was one representing each BHA region. We conducted an IPE survey, which included qualitative and quantitative data for both general perceptions of the funding's performance and sector-specific programming. And thank you to many of you whose organizations and who may have even participated in that survey. The third method area was a deep dive where we reviewed all documents for 30 proposively sampled awards and then did follow-up interviews with those IPs and AORs. We also, through a shallow dive, reviewed the remaining 81 awards where final reports were available, and we reviewed those awards for outcome level themes and missing indicator values. And finally, there was all of the monitoring data analysis from all of the data that was provided by many of you through your awards to BHA, and that was to do analysis for 45 priority indicators. We then conducted a triangulation of the findings, and all of our key findings that are provided in the report today are supported by at least 3 data sources each. Next slide. Now, as we go into the findings, we want to make sure that there's a bit of engagement from you and that you have the opportunity to also share with us some of your reflections on these findings and what resonated with you. We'll also be collecting questions in order to have time for discussion at the end. And if you haven't used this tool before, it's very easy to use. You don't have to sign in or anything like that. You can bring it up on whatever device you have. So go to this link, which is the padlet.com link at the top, and also has been posted in the comments. And in this link, it'll bring up a page where you can write comments as we go in this presentation. There's 4 columns that represent our key areas where we'd love to hear from you, questions and comments. The great thing about using Padlet here for comments is we'll have them all in one place. And even if you want to write your questions still in the Zoom chat, that's fine. Our team members will transfer it over into the Padlet so we can see them all there and have it for discussion at the end. Another great thing about Padlet is it is all anonymous, and if someone else has written a question that you had, you don't have to write it again. You can also just do a thumbs up on the actual comment, and if something resonated with you that someone else wrote, you can also do a thumbs up, and that gives us a good idea of what your responses are to the findings and presentation today. And let me I know I didn't read through the Padlet columns, but in case you haven't pulled that up yet, just really quickly here, what we are hoping to hear from you on are what questions do you have for the evaluation team? Again, that will guide our Q&A. What findings or recommendations do you think BHA should really focus on from what you've heard today? What findings and recommendations do you think are most important for IPs to address for future programming? And what are key questions or themes to raise in future evaluations around COVID funding and response? So those are the main areas that we're hoping to hear from you on. And now we will go into some of the high level and sector specific findings from the evaluation. And as we won't have time today to go into great detail on the evidence and specifics of all of the points we're presenting, do let us know also in that Padlet what you want to hear more about, and we can get into that in the discussion at the end. So did the funding reduce COVID-19 transmission? That was actually the first objective of the funding. And we found that the supplemental funding contributed to the behaviors necessary to reduce transmission. It improved the knowledge of COVID-19 risks and protective measures. also reducing some of the fear and stigma and confusion around the novel disease, and that it contributed to the perception, or it supported the perception that transmission was reduced. And that came out very clearly from project participants and from partners. And this is mostly through all of the health and WASH sector activities, including Rcce, the risk communications and community engagement. Unfortunately, because surveillance data doesn't exist in a way that we could actually measure disease transmission, these are the ways that we answered this question. Were the secondary impacts mitigated? This is now the second objective of the funding, was to mitigate the secondary impacts of the pandemic. And we found that the economic and food security secondary impacts were mitigated, in particular where the nutrition and food assistance sector and multi-purpose cash assistance, MPCA, types of activities were implemented, as well as other income related or livelihood activities through other smaller sectors we'll discuss. Awards that were narrower in focus, like health or WASH only, were found to have left out being able to meet some of these needs that arose in mid-2020, where these severe secondary impacts became very evident. And that's where half of the second half of this supplemental really shifted because of BHA's design in order to meet those needs. However, partners did try to address unmet needs by layering activities with their other program activities or with other donor funding. Next slide. And then, did the funding support the continuation of humanitarian programming and core health services? This was the third objective of the funding. And we found the funding did support the continuation of key humanitarian services that may have otherwise been disrupted or exhausted in 2020 due to the effects of the pandemic and the challenges. This allowed IPs to leverage, or by allowing the IPs to leverage the supplemental awards to complement their ongoing program, they were able to support the continuation of their key activities, and were IPs closely coordinated amongst other actors, and in particular with their known community partners. This is where the continuation really was supported. In the IPE survey, we also found that about 2/3, according to those partners, about 2/3 of the partners did say across their sector activities that the supplemental award did support the continuation of their key sector assistance. And then the other third, how we interpreted that was that, you know, there were some new activities also that started in response to the pandemic, and so it wasn't a continuation per se. Next slide. Were BHA priority indicators achieved? And so this goes back to all of the monitoring data that partners submit to BHA for the key required indicators. And the vast majority of the awards did achieve their targets for the priority BHA indicators. And that's in particular for the health and WASH sectors where we had the most indicators. These were mostly output indicators. However, there were some intermediate type of outcome indicators, such as around improved knowledge and behavior change. As you all know, with for example, WASH sector, when it comes to the protection and the food security and livelihoods related indicators, they were more limited in what was reported. There were numerous issues related to the quality and completeness of the award data that was submitted to BHA, and this did constrain the evaluation's full view of the funding performance. Next slide. Did the 6-month timeline affect programming? 6 months here representing the original time frame for most of the awards. That was not including then extensions that were added on. And in talking with IPs and doing the field work that we did find that operating under this compressed timeline tended to hinder the implementation of certain programming. So activities were selected that could be implemented within that short time frame. But if there had been a longer time frame to plan for from the start, IPs said that they would have perhaps selected some different activities or some different strategies. That compressed timeline for what ended up being a protracted pandemic did also limit the sustainability of some project results or the time for adequate community capacity building or handover. In the quote here that came from a partner award report, it says, both GBV, the gender-based violence, and child protection activities require an extended period of time to deliver quality programming, which is built on relationships of trust with parents, survivors, and communities. Next slide. What did we learn by sector? Here we will go into just a few of the results because of the compressed time today, but a few of the key results, the successes and lessons learned by sector. First here, we will get into what some of the overall themes were, these cross-sector themes that really supported the most success or the most effective approaches. And so overall, what we found was that layering activities from different sectors was most effective, and we'll get into some examples of that on the coming sector slides. Also, the any kind of cash or voucher-based assistance, including food assistance, was very relevant, very appropriate, especially for reaching newly vulnerable populations. And that strong community level engagement was absolutely critical. We heard from some partners that we interviewed that they worked more closely with community leaders and other community or local institutions than ever before during this pandemic, and that this was critical for timely and relevant targeting and their ability to deliver assistance in those difficult first months of the pandemic. And finally, the adoption of remote activities and monitoring technologies was a big innovation during the pandemic, and partners really shifted and adapted quickly to use new kinds of technologies to both monitor their activities as well as even to implement. Next slide. First, getting into the health and Rcce sector, or health sector, which would include Rcce. We'll look at what we've learned. For health, on the top right in the blue box, you'll see that this is just one example of an achievement from the supplemental funding in 2020. And that is that 6.8 million participants were screened for COVID-19 through this funding and through the awards of this funding. And some of the successful approaches around the health awards included supporting health facilities, including primary health centers and hospitals, in various ways, such as through infection prevention and control, IPC trainings and protocols, providing hand washing stations or other equipment, and setting up COVID-19 screening and referral systems within these health centers. Also coordinating with ministries of health, clusters, and other health actors on surveillance was important. And strengthening the capacities of community health workers and the frontline health workforce in COVID-19 infection prevention and control, IPC, and triage practices. Finally, mobilizing telehealth, mobile community health, or rapid response teams to support home-based case management of mild cases, for example, or to reach hard to reach or isolated communities in humanitarian contexts. These different types of mobile approaches or remote approaches were really critical. For Rcce, over 137 million participants were reached with health and hygiene messaging around COVID-19 through the supplemental. And some of the successful approaches included truly community-based Rcce, which is building community trust, working closely with trusted partners in the community in order to disseminate communications and messaging using platforms that were really culturally and context appropriate, and even adapting messaging based on different rumors or the stigma and fear that was evident in some communities. And Rcce combined with the IPC support at health centers and that case management and remote case management noted on the previous slide were together really key to combating some of the rumors that there were circulating around the novel disease and helped people to not fear seeking care. IPs specialized also, there were some IPs that really tracked the spread of rumors and misinformation and helped with tailoring messaging or even identifying community influencers who could help to disseminate good messages, such as through social media platforms, which were also really interesting and important approaches. Next slide. For the lessons learned in the health sector and with Rcce, there were a lot of difficulties in obtaining supplies, partly because of this just global supply chain challenges, and in hiring medical staff. And this led some partners to really focus on the community health workers, CHW support, and also to work together to coordinate to get some critical supplies. And that includes PPE, where there was also a restriction at the time per BHA. Another lesson is around isolation units, which were really underutilized in a lot of contexts. And while we didn't get to do a deep dive into this specific intervention, we feel it really should be reviewed in greater depth for future pandemic responses. And the support for mental health of frontline workers was really critical, though it often did come late if it required developing some new kind of programming around it or developing a new curriculum that might be online, for example. Next slide. Now for water, sanitation, hygiene, the WASH sector. Some of the key successful approaches for WASH sector were supporting adequate WASH facilities in health or nutrition facilities, or supporting water, sanitation, and health in these health and nutrition, or in hygiene in these health and nutrition facilities. Also linking cash with WASH hygiene kits or non-food items, NFI, was also viewed as very effective, as that helped to ensure that the NFIs from the WASH kits weren't sold in order to pay for other food or urgent household needs, and could actually be used for the household to help to mitigate the spread of COVID-19. Also sourcing these NFI items locally if possible, and adjusting to community feedback or guidance around the most appropriate WASH inputs. One example of that we saw in the Nigeria case study was a preference for using a washing kettle, and partners who shifted to setting up that kind of hand washing station that would be more culturally appropriate. And as an achievement for the WASH sector, one example is a 20 percentage point increase on average from the baseline indicators that were available and participants' knowledge of 2 or more COVID-19 protective measures. Next slide. Some of the lessons learned for WASH sector. Overall, the WASH awards overemphasized hand washing and surface sanitation as key preventative response measures. And community WASH infrastructure investments required a lot of sustainability planning and capacity development activities, some of which, because of the short-term nature of the funding, just weren't able to be done adequately, and was really difficult to achieve in a 6-month time frame. One example of better sustainability that may have been integrated into WASH activities if there was a longer time frame to start with would be providing hand washing stations within a health center, for example, and procuring hand washing stations that were plastic or that were not going to last very many months, as opposed to setting up a hand washing station that could actually endure future many waves of this pandemic, as well as post-pandemic IPC in that center. Next slide, please. Moving on to protection now. For protection, one of the achievements from this supplemental was that 80,401 participants were able to access GBV services through this funding and through the work of your awards. Some of the most successful protection approaches included incorporating various remote services or virtual and digital approaches for psychosocial support, PSS activities, for referrals such as hotlines, for community sensitization activities overall around protection issues. And one example that came from our Iraq case study was that project participants shared they felt even more comfortable accessing mental health or psychosocial support MHPSS services over the phone than they would have in person. And so by shifting to remote provision of some of these services, they were able to reach more people, or people were feeling more comfortable accessing those services. Also, integrating protection activities with other sectors, such as with health or with various food security and livelihood activities, was really critical. The majority of the protection sector funding in the supplemental did go out through multi-sectoral awards. One example of that integration would be delivering the COVID-19 Rcce activities and messaging along with GBV together. Next slide. And for lessons learned, shifting to sensitization was important because it was difficult to get the level of trained professionals to meet the increased need for case management and other direct services. And also with that lack of trained professionals, it was really key for partners to shift to strengthening local or civil institutions' abilities to deliver these services. Also, sharing training resources across protection actors was key because a lot of different curriculum development happened, which can also be time consuming. And protection activities in new areas or with new populations requires a lot of time to build trust and develop community relationships. And so protection activities that we're trying to reach totally new populations or new areas faced a lot of challenges. Next slide. Moving on into our food assistance and multipurpose cash or MPCA learning. Some of the successful approaches here were really around shifting to any kind of food assistance and cash and voucher type modalities that could be more flexible, and really through top-ups, through added distributions, we're able to reach new populations, to counter the negative effects on food insecurity that were caused by lockdowns, help to address rising need as well as issues with inflation. And this assistance, for example, that was provided through World Food Program country programs, the evaluation estimates was able to reach, just through those WFP programs, over 2.5 million participants. Next slide, please. Here we have a few quotes from some of the project participants that we talked with. In Iraq, a participant said, "We are suffering greatly. Work has stopped and material resources are very little or non-existent. It has challenged us more economically than the disease itself." And in Colombia, "We are thankful for the assistance we received at our moment of need, that we were not forgotten." These perspectives really showing how urgent the secondary impacts were on many of our target populations. Next slide. There were the agriculture, food security, or AgFS sectors, as well as the economic recovery and market systems, ERMs, that were supported. For AgFS, implementing measures to promote the safe functioning of markets, distribution centers, or key points in the food value chains was a key approach that was successful. Also, direct support to essential agricultural value chains and service providers affected by the pandemic. One learning was that it's a sector that's very difficult to complete in 6 months' time, or with a newly vulnerable population, such as the peri-urban populations. And it was most successful if it was layered with another existing program or with another actor's existing programming. Next slide. And for the Erm sector, many of the activities revolved around hand sanitizer, mask, or local soap making, including trainings with, for example, women or local tailors. And this helped to support in a very multi-sectoral way the hygiene, health, and livelihood needs of those participants. It often included protection activities as well, though it had the potential in some places to cause some protection risks, and that had to be monitored very closely. One learning here also is that any other income generating activities beyond those that were very COVID specific, noted in the first point, and unless layered with a pre-existing program, was really not feasible within the short-term response period. And with that, we will shift over to the Padlet again here. We really want to hear from you. We're going to pause now that you've heard general and sector-specific overall findings from the evaluation. And before we move into the recommendations, we want to take you back to that Padlet and remind you that we're gathering your questions in the first column there on the left that we'll have time to address after getting through the recommendations in just a few minutes. And then for the middle two columns around what findings or recommendations you think are most key for BHA or for partners to focus on for future programming, we hope that you'll open up that Padlet and have it ready also for thinking about the recommendations. Also, what are key questions or themes that arise as you listen to this presentation that you think should be covered in future evaluations around the COVID funding? We'll actually pause for just about 45 seconds and allow you to gather your thoughts here and put in any questions you might have. Thank you all for the questions that you've already been writing, and please do click the Padlet link in the Zoom chat or type in the URL that we have here on the screen and do bring that up on any device that you have now. And continue to provide us with your questions, your comments, and your reflections. Now, what does this mean for the humanitarian community moving forward? In our evaluation report, we gave BHA 6 recommendation areas, which you can find also in the evaluation findings brief. And here we will quickly cover how humanitarian partners can also respond to those recommendations. The first recommendation area is around cash coherence. For BHA, we've recommended that they develop a cross-sector cash guidance and related outcome indicators. And that's how various cash-based modalities that are funded under various sectors can be implemented and combined across sectors to provide to be a really critical tool in emergency programming. And as programming for humanitarian partners, we would hope partners that we know many of you all are already doing this, so we hope you will continue. And if you haven't considered this already, we would hope that you would consider incorporating food assistance or MPCA more into cross-sector project designs, and also support the layering of food assistance or MPCA with other actors or within the activities of your own program. Also, that you would measure food security or other intermediate outcomes related to food assistance or MPCA programming. Next slide, please. Recommendation area 2 is around the momentum for localization. To BHA, we've recommended that there's increased investment in local organizations that respond to the ongoing shocks, and that their capacity is built up in order to be included as formal partners in future pandemics. That might be as a first step, that might be included as sub-award partners or as direct partners eventually with BHA. So programming considerations for humanitarian partners is to continue to engage local actors and stakeholders in project design and decision-making, which was really an important and effective point in this evaluation that many partners did very well, but also to propose sub-award partnerships with local organizations. For this funding, there were about 13 total awards that had at least one local or national organization as a sub-awardee. And also continue to develop the capacity of local institutions that you work with and in your operational areas ahead of time, ahead of any kind of global emergency or novel disease, pandemic or outbreak. Recommendation area 3 is around strategic investments and coordination. To BHA, we have recommended that they develop a strategic coordination strategy for pandemic and global emergencies, and in particular, to provide clarity for how the HCIM sector, which is the Humanitarian Coordination Information Management sector, can help to support that coordination strategy. Programming considerations for humanitarian partners related to this recommendation are to improve cross-sector coordination mechanisms overall. In this evaluation, we found that within sector coordination was very strong, such as through the clusters, but that cross-sector coordination happened far less. And to develop contingency or preparedness plans ahead of pandemics, such as with government actors where possible, and to develop memorandums of understanding between actors to facilitate logistics and the distribution of key supplies in advance of an emergency. And that would include, for example, key NFI or PPE. Recommendation 4 is around the very valued guidance provided through the BHA and IP relationships. And to BHA, we've recommended that they continue to support BHA's very strong and important direct communications with IPs, such as through their award managers or their field contacts, and that they continue to use that relationship as a way to disseminate BHA priorities and to communicate key guidance. Programming considerations for humanitarian partners around this include maintaining those channels of communication with BHA in country or the field contacts ahead of global emergencies, and ensuring that that is a frequent enough communication that as partners, you feel that you really understand and can follow BHA's policies and priorities, or if indicators or reporting are unclear, to utilize that relationship in order to ensure that those are of high quality as well. And that actually leads us to the next recommendation area, which is around the M&E for humanitarian decision making. To BHA, we have recommended strengthening the award data quality and monitoring system in order to improve its utilization for decision making. And of course, that will go hand in hand with you all and the partner data that's submitted. So as programming considerations for partners, continue to or establish accountability practices that will ensure that BHA priority indicators and final reports are completed and uploaded to the BHA award reporting system. Ensure that indicator and participant data uploaded is the most current and that it matches the information in the final reports. And discuss these project results with the BHA award managers and field contacts during implementation in order to promote its use for adaptive management and programming. And the recommendation area 6 is around novel pandemics, and that novel pandemics will always involve great uncertainty, and that the awards must be designed accordingly. To BHA, we've proposed a directive that would allow for longer award timeframes and greater flexibility for future funding of this nature. This recommendation is mostly applicable to BHA, but for humanitarian partners, we hope partners will consider designing emergency or pandemic programs that can strengthen capacity and sustained results over 1 year, and also allow capacity to be built and more successful approaches to be implemented by layering with other donor funding as necessary, and also to design activities with the readiness to be able to pivot approaches as understanding of a novel disease and its risks may increase. That's it for the recommendation areas. And as a few notes to conclude, the evaluation found that BHA and humanitarian partners faced many challenges in an unprecedented global emergency in 2020. And the response showed their capacity to act swiftly and to engage locally. Partners programmed the funds efficiently and adapted approaches where possible to meet community needs and feedback, including shifts to new remote and innovative approaches. Overall, it was a tremendous response that continues to this day. And we look forward to continued learning with you all to improve future outbreak and novel disease response. With that, we'll open it up for Q&A and discussions, and I will hand it over to the senior advisors on this evaluation, Dr. Nancy Mock with Tango for this evaluation, and a Tulane University professor, and Tim Frankenberger, president of Tango, to help lead this, this discussion. Over to you, Nancy.
Great, thanks. We have very little time and some very interesting and deep questions. We'll start with the questions from the tablet. One of the first questions was whether or not we really looked at a comparison between areas that got assistance and didn't with respect to COVID cases and deaths. And just a really quick one on that. This evaluation was for the period of 2020. There was very little surveillance data available and nothing that would have allowed the establishment of counterfactuals, at least not that we saw. So we did not look at that directly. We really looked at indirect measures such as behavioral change and so forth. And then I think we've got both a question and an answer on the type of platforms that were used for Rcce, WhatsApp, Facebook. There were a number of quite interesting adaptations. IPs adapted quite quickly in the field and used platforms that had the biggest bang, actually. The third question was related to isolation units, and where we generally didn't find those as being very effective interventions. Did we find examples where they were, and could we compare and contrast where they were and not? And I'll punt that to you, Marietta.
I'm on mute. Around the isolation centers, Nancy?
Yes.
That's right. We, I think in the case studies, there was definitely evidence around that. And of course, because of the great fear and stigma that tended to arise around a novel disease, the evidence we collected was that it was more effective to provide that home-based type of care. And so a lot of the isolation centers that were set up were just underutilized, and maybe they were utilized by humanitarian staff. And so, you know, that intervention could be reviewed and its effectiveness in that way, but not as much by communities.
Next on the list is the extent to which we were able to evaluate whether the IP's staff were actually in the field. And in general, we were able to do that specifically in case study countries. So we could, through the case study, 3 case study countries, we did much more in-depth interviewing of both staff and, this answers another question, beneficiaries or participants, sorry, that we did numerous, in each country, we did an average of 50 focus group discussions and numerous IP interviews with field staff. And so at least I think that the extent to which staff were in the field varied quite a bit from place to place and partner to partner. With respect to many interventions, staff were in the field, at least the one that I can speak to, which was Iraq. But the sort of counter factor there was that in, you know, IPs mentioned that they were very concerned that they were careful about field protocols for protection of participants and staff. So there was a tension between needing to protect staff and participants and also getting to the field. I don't know if anybody else wants to say something about the other cases.
I
No?
think that's right. I think that's right, Nancy. But also where partners couldn't have a lot of staff in the field, they just relied so heavily on local partners and local staff to be able to help to be there. And I think especially in those first months of 2020.
Another question is the extent to which findings differ by gender, age, and other demographics. And you know, clearly there were some gender differences, but they're contextualized. And for example, in Iraq, we found that women were particularly concerned about prioritizing cleaning supplies. And also that there were specific issues with respect to gender and women's ability to access health services. So these are, I think, contextualized quite a bit, but there certainly were differences, and it's definitely worth looking at those differences in these kinds of contexts. Anybody else want to say anything else about gender specific?
Yeah, I think so on the protection side, one of the things that came out very clearly in the Nigeria case study was that once food assistance was being provided, either as food or cash, the amount of violence that was going on within the households actually went down dramatically. And so they said that hungry husbands are angry husbands. And so that made a big difference in terms of reducing the gender-based violence.
Yep, definitely. Anybody else have any comments on the gender issue? Definitely important, the GBV that resulted from the lockdowns. There are two, sort of one comment and one question about pillar 3, being that, you know, it definitely was, a, you know, the deliberate decision that BHA made to try to maintain services was in fact quite important, and it did protect many people from losing assistance. Now, did we estimate how many did lose assistance? No, we didn't do that to my knowledge. And Marietta, you can confirm. But what is also important is that there are trade-offs between pillar 1 and 3. So preventing the spread of the disease versus continuing services, it often can be a trade-off. For example, in Iraq, where the deliberate decision was made to keep assisting conflict-affected populations when a lot of the heavy transmission was going on in the southern part of the country. But the decisions, you know, of these trade-offs have to be made, right? And we actually concluded that the trade-offs that BHA made were very rational ones. And then there was a question about the ag sector, and one of the participants in this session was surprised that ag was funded. So my recollection is ag was quite minimally funded, very minimally funded. And I'm not sure Marietta or Tim or others in our team may know where specifically ag was funded and why.
I think Peter can answer that one for South Sudan. Actually. Peter, you there?
Yeah, sure. I'm just looking for my note here now on the agriculture. We had some examples like where agriculture was layered with other assistance. So an example where urban gardening, training, vegetable production, and such were layered with food and cash assistance. So it was in sort of in that context, it appeared to have a positive impact on food security.
And that was in South Sudan, right?
Yes.
FAO working with WP there.
Also, AgFS and Erm sectors together represented just 1% of the total funding. So they were quite small sectors overall, of course, but pretty targeted in what kinds of activities they did.
Sorry, I was switching back and forth between the tablet and the Zoom. I think that we also had some suggestions as to which recommendations and findings should be highlighted, and we might want to just review those for a second. Hold on. Doing my acrobatics here. Mobilizing telehealth, mobile community health, the rapid response teams to support home-based case management of mild cases was suggested. Longer term and more flexible awards. And here the comment is that the recommendation isn't just applicable for novel pandemics, but and we all recognize that longer term responses are really are the norm rather than the exception. The localization momentum, promoting some awards, partnerships with local organizations and developing local institutions' capacity ahead of emergencies. I think this should be emphasized. We mentioned before again, pillar 3. And I think, do I miss any here? And certainly if any of the participants want to speak up if they think that we haven't addressed their questions or their recommendations.
On the screen here, could we scroll up to the top of the Q&A? Because I think there are a few there, not sure if they were totally addressed. in terms of the supply of PPE, that question. So supply of PPE was challenging due to the huge demand on these items globally. How did you assess the impact of this challenge on the entire response? Nancy, did you already address this one?
No, we did. The PPE question was really important, particularly because of the time frame of this, award evaluation is 2020. And we know there were many problems with obtaining PPE, both because the administration's policy was not to allow partners to purchase PPE that might be competing with the US. So there were many issues. Now, the flip side is that the IPs were highly creative in accessing PPE through other mechanisms when they could. So it was an issue. I think there were some creative responses to it. Would this, this issue certainly will come up again and again, right? In a pandemic context, it was a bit more acute because of the particular administration's approach to sort of the global dimension to this pandemic, but it will come up again, for sure. And certainly it came up in the vaccination discussion. So it is quite important. And then I think
that we were able
so
to
what
cover
was the most effective approach to tackle and reduce COVID-19 related stigma in communities? That again, is very contextualized. It depends on how that stigma plays out. We had mentioned that remote methods actually often were one way to mitigate that. Also, the trusted partnerships issue. Again, BHA made the decision to focus on trusted partnerships that already had trust with communities. This was another way that that stigma was mitigated. The trusted partnerships, again, can't be overestimated in context of pandemics, particularly. I think we've got them all, though I can't, if any new ones have popped up.
Yeah, I think as we're getting to the top of the hour, we should probably close out now, but thanks for all of those questions that everyone submitted. Thank you for your other reflections on some of the key findings and recommendations, as well as themes to look at for future COVID evaluations. Really appreciated everyone joining today. And this webinar recording will be shared next week, along with some evaluation findings briefs that will be provided in English, as well as Spanish, French, and Arabic. And so we hope that you will circulate those and share those with your colleagues. We could not have conducted this evaluation without your valuable input and your willingness to share your perspectives and all of your learning. And we really do hope that these findings will help to improve future programming for emergencies, as well as for any kind of outbreak or pandemic response. So thank you again for joining us, and have a great day. Goodbye.